invite our speaker to the microphone this afternoon. He is Dr. Richard Lewis, and like me, he's the son of a coal miner. Was born in Cairo, Maesteg, and qualified at Leeds University during his house jobs at St James's Hospital, Jimmy's, before coming back to Wales straight into general practice as a trainee in his home village of Cairo. Some of you say Cairo, see, but if you're a Welsh speaker, you'll say Cairo. Before completing his GP training with stroke medicine at Surrey, psychiatry at Park Hospital, and trauma and orthopaedics in Bridgend. During the following 14 years, as a partner at Woodland Surgery in Cairo, he fitted in medical director to the Bryd Glamorgan Family Health Service Authority, medical director to ambulance services in Wales, provided voluntary road accident services and established with other volunteer schemes in South Wales. He has been medical advisor to St John's Ambulance in Wales and continues to advise the organisation on health matters. Last year he was appointed as a Deputy Lieutenant of Bryd Glamorgan. Richard took up the role of Welsh Secretary to the British Medical Association in 2003, but has continued to undertake part-time GP work, police surgeon work, and for the last 4 seasons, Honorary Medical Officer to Maesteg Harlequins RFC. We beat them twice. Just returning from Hong Kong, having provided medical covers to a touring tennis charity team that successfully secured the shield at the Hong Kong Tennis Tournament, a unique achievement for a British, predominantly Welsh squad. And it's now my pleasure to call on Dr. Richard Lewis to give us this week's talk.
Thank you very much, everyone, for inviting me along to speak with you today. And having spoken to colleagues over lunch, there was lots of things I could have talked to you about. In fact, I probably could have talked more about the rugby than about the Mets and stuff today. But I'd already pitched for this, and so what I'm going to talk to you a little bit about is the role of the British Medical Association. So a bit of historical information about that, its role in Wales as I work for it, and a little bit about the current situation around health services. Hopefully I'll try and go through things a little bit, there'll be quite a few slides, but we'll go through them quicker, because I thought maybe listening to some of the chat over lunch, that maybe it would be useful for some time for questions and chat about the various things that will come up. So, without more ado, I'll move on. I was, as already been said, born in Cairo and went to school in Maesteg Comprehensive School. Roger, one of my teachers, you probably remember that spotty bloke, which is why I put it up there. Roger, just to remind you what I used to look like. Very kind of you to say I haven't changed very much, but that's what I looked like in 1978. And I went away to Leeds University to train, did a number of jobs there, and then came back to Wales to do medicine, went into general practice, and have done a variety of jobs, as you've already heard, and probably most proud to be the Honorary Medical Officer of Maesteg Harlequins. I know I'll have to dig that one in and let them know I've told you that twice. The history of the British Medical Association, I've been Welsh Secretary, as you've heard, since 2003. It's got a 175-year history, was established in 1832 by a guy called Charles Hastings, that's him there, who was a GP in Worcester. And he created, first of all, a bit like your group, I suppose, what was called back then in 1832 the Provincial Medical Association. And its primary aim was to bring mainly people from London, because most of the expertise in those days was based in Harley Street in London and in London hospitals. And doctors who were providing services out in the sticks really felt that they were pretty much undereducated, if you like, or at least they didn't have that information, and he felt it would be a good idea to set up a group to bring people from London to lecture to local GPs in groups. It, as I said, was originally called the Provincial and Medical Surgical Association, started in Worcester, and was meant to be friendly and a scientific forum where doctors could advance and exchange medical knowledge. The organisation, as it was then, rapidly spread across the UK, with groups being formed in various localities, and mainly it was around education, bringing speakers to these local rural areas, so that people could really get the updated information on what was the cutting edge medicine at the time in London. The name was changed to the British Medical Association in 1855, and ironically, despite the fact that the association was set up to drag expertise out to the rural areas, they went and set up their headquarters in Tavistock Square, right in the centre of London, and that's where the headquarters currently sits. You'll have seen it on the news, tragically, a few years ago when the 7/7 bombings happened in London. The bus that was blown up outside the British Medical Association, and a lot of the doctors who were in meetings there at the time assisted in treating and comforting those who were killed and injured. The early days of the British Medical Association saw them trying to improve the standards of medicine in the UK by getting rid of quackery doctors, well, they weren't doctors, but quackery quacks who said that they had qualifications but had not actually had formal education. And they pushed for the establishment of the General Medical Council, which still exists and regulates doctors, and the creation of a medical register, again, which still governs us in a sense in terms of maintaining doctors' licence to practice. At the beginning of the 20th century, the BMA started to organise itself a little bit more formally, and started off with an annual conference and a representative body which still meets annually. It usually meets towards the end of June, where all members of the association, up to 300 or 400 delegates, come together to create the BMA's policy on a whole range of matters. The BMA during the both world wars was instrumental in organising doctors across the UK to both become army medics, but also to provide the health provision back home, while many doctors went into the front line. The BMA house in Tavistock Square was opened in 1925, and the ceremony, as in this picture there, I think, shows King George V and Queen Mary attending the opening of Tavistock Square. Over the years, it continued to advocate on a range of health policies, and was certainly a party with the government in debating the setting up of the National Health Service in 1948. And while the BMA has been sort of recorded as being anti the National Health Service, looking at the archive information, the BMA was not anti the National Health Service. In principle, they very much supported it, and there's lots of documentary evidence to suggest that. But they were concerned about the way in which it was going to be imposed on doctors at the time, both consultants and GPs, and there was a lack of certainty about how the financial arrangements and the payment was meant to work. In the 50s and 60s, the BMA gave evidence on a range of issues, from the homosexuality, for instance, and the acts on that, laws on divorce, and had policy on trying to get the government to improve the various legislation to support better health in the UK for patients and in support of its members' wishes. In 1974, the BMA became a trade union and remains a trade union today, representing its members. The BMA now speaks on behalf of doctors at all stages of their careers, from medical students, consultants, GPs, or people. We campaign on a range of global issues, from obesity and the threats of smoking and alcohol and you name it, and the BMA's got some opinion on it somewhere. We contribute to more recently debates on, for instance, assisted dying and the whole issue of doctors' involvement or not in that, and also produce a lot of reports. A recent one was on genetic engineering, for instance, or in vitro fertilization, or cutting-edge medicines where there may be an ethical or moral dilemma for both patients and for doctors. With increasing devolution, and the lobbying on these various things obviously is to Parliament, members of Parliament, health secretaries and so on, but since devolution took off, just before I took up the role as Welsh Secretary in Wales, we lobby the parliaments and assemblies in each of the devolved nations, and as well as the office in Cardiff, we have offices in Belfast and Edinburgh, as well as the headquarters in London. The BMA now has, across the UK, over 154,000 members, doctors and medical students, and as I said, we represent the voice of doctors in all situations and represent their collective opinions. One of the key elements or provisions of the BMA since its inception has been a journal, the British Medical Journal, which I'm sure people will have heard about, and we now have a global publishing house, the BMJ Group, which not only produces the British Medical Journal but produces journals in all health specialities that are sent all over the world. Increasingly, as you're aware, many things are now becoming computerized, digital and technical, and so we, through the BMJ Group, produce a lot of online learning where even in remote parts of the world, doctors and healthcare professionals can access online learning or even contact specialists in groups to get information or help to enable them to better treat their patients across the globe. We don't do certain things, we don't defend our doctors. As a trade union, we representing our members, we represent them both collectively in terms of collective bargaining on contracts and pay and money, but we also act on behalf of individual doctors who get into trouble in the workplace, but not around clinical negligence, for instance, which is undertaken by other defence organisations. And we don't register doctors, the General Medical Council does that. and we don't discipline them, but we do speak up for them, and we don't and are not meant to recommend individual doctors to patients, for instance, as a referral type of system. In Wales, the first Welsh branch of the British Medical Association came into place in 1852. And once again, as with the rest of the BMA, the local organisation proliferated rapidly across Wales to the point that they had to establish a Welsh council, and the first Welsh secretary, Dr Porthcawl, was appointed as late as 1967, and I'm only the fifth Welsh secretary in Wales. The office in Wales replicates the way in which the BMA operates across the UK. So we have a Welsh Council that's made up of democratically elected members from different specialities, so GPs, consultants, public health doctors, academics, medical students, junior doctors, and each of those specialities have democratically elected committees that represent their particular interests. And we have at a local level, and Dr David Parry has been involved in our local activities, we have local divisions that are geographical, sort of geographically based, that support doctors across Wales, get their opinion and give them information around what the BMA is doing, and also get feedback from them. And from those various bodies, we take the delegates that go to the annual conference to make the policy that the BMA then works on through its natural year, which runs from July through to the following annual conference. We also have in each of the hospitals and health boards in Wales local negotiating committees which represent consultants, and again work with the health boards and their management to try and ensure that services are either improved or make sure that they don't deteriorate, and our doctors are contributing appropriate information to service development. GPs locally are represented not by a BMA body but local medical committees, which are statutory bodies under the Health Act in Wales. The fact that it's the Welsh settlement for Wales, and in Wales we have over 7,500 members. The current divisions representing the geographical areas pretty much follow the old county lines, but every member of the BMA is affiliated with one division or another, which allows them to have a voice and an opinion and an influence on the way in which the BMA works. Local medical committees also that work on behalf of GPs, again made up of democratically elected members, but not a BMA body, although we work very closely with local medical committees and in fact host an annual conference of local medical committees in Wales, again which forms GPs' opinions on health and the sorts of things that they think should be changed or altered in order to either improve services or improve the lot of GPs in Wales. And through those policies that they come up with, the BMA will then lobby government and health boards and health organisations to try and bring about the changes that our members want. I've mentioned local negotiating committees. I thought I'd just touch a little bit about the NHS in Wales as it currently stands. We have the provision of primary care and community care services by general practitioners across Wales, of which there are about 2,000 plus. Hospital services and clearly ambulance services that you're aware of, and some tertiary, what are called tertiary centres for the provision of cancer services, for instance in Velindre, as well as the community care services generally. the structures in Wales, we've now got these 7 health boards that are meant to be integrated and therefore responsible for both primary, secondary hospital-based services and community care services, and should work as an integrated body. That while they've been in existence for quite some time now, I think it's fair to say that the degree of effectiveness by which they integrate and provide services is variable across Wales, and I'm sure as patients, if you are accessing that, you will see that things, while broadly I think are a reasonable standard in Wales, there is still significant room for improvement in the way in which services are delivered. They're supported by some NHS trusts, the Cancer Trust, Velindre Trust, which houses a couple of other things like the blood transfusion service and so on, the Welsh Ambulance Service, and another trust which is Public Health Wales, which is looking more at the health and well-being of the population, and how do we improve and maintain people's health into the future. So some of the challenges facing, I suppose, all health services, but particularly in Wales, is how do health services sustain high quality and safe services in the here and now. That's what their business is every day, to make sure that people get access to the best and safe treatment in a timely fashion, while at the same time pursuing a programme of health promotion and illness prevention around lifestyle choices such as smoking, alcohol, obesity and exercise. And the BMA will continually lobby on those sorts of issues to try and get the Welsh Government and the health services to deliver those things to the best possible standards. I think the forum that you've created here is, I think, a real exemplar for how people's health and well-being can be maintained, because I think the very fact that you are meeting regularly and having the interaction that you're having maintains people's, I think, independence and well-being continually. And I think if you would be a good, very excellent example, I think, for how perhaps communities could contribute to the health and social care of the population in Wales, across Wales. Some of the challenges that face health services, again, that the BMA is very much cognizant of, is that we have an increasingly ageing population. We've got rising hospital admissions and demands on hospital services. And there are increasing costs to providing healthcare, because we can now deliver more and more advanced care, and all that comes at an expense. People clearly living longer. The Welsh population growth in Wales is projected to increase, certainly the 85 plus year olds in Wales. I think for women, I think we're going to see a 79% increase in women surviving beyond 85, and male 79% and 34% increase in women living beyond 85 years of age. And now I know we don't want to, but as we get older, clearly we do have increasing chronic health problems, and that puts an increasing burden on the way in which services can be provided. So anything that we can be doing early in life to improve people's health and well-being into the future is going to allow us to have more sustainable health services. It's predicted that there will be a 2.5 billion funding gap for the NHS in Wales through Welsh Government funding by 2025 if the Welsh Government and the health services don't change the way in which they provide services. And that means promoting healthier lifestyles, making sure that people are staying fitter and healthier for longer, and becoming less dependent on hospital-based services, and improving and enhancing the way in which primary care and GP teams are increased in order to support people better in the community. But that's not proving to be very easy for either the Welsh Government or for the health boards that have to deliver on these things. They're increasing, on a more political theme, increasing variation between the health systems across the UK, and particularly between England and Wales. The Welsh Government and Wales is very committed to a socialist Bevan type principled NHS. Within England, we're seeing increasing diversity in the way in which services are provided, such that there's greater private sector and independent sector provision of services, and to some degree fragmentation of those services. But recent studies have shown that overall, despite the differences in the way that services are provided, the quality and standards, while variable across different parts of the UK, are broadly delivering the same, about the same level, despite the political rhetoric that certainly we're hearing in the run-up to this general election, where parties are using the health service very much as a political football, and governments and different parties are using Wales in particular as an opportunity to score political points. The BMA recently, in the last few months, launched a massive campaign across the UK to give politicians the message that they really shouldn't be playing games with the NHS. It's too important and too valuable, and that it would be better if they were working more collaboratively together to improve services, rather than constantly bickering and backbiting about the way in which services are delivered. The challenges facing the BMA in Wales currently are the grappling with the differences in health services and talking to Welsh Government about those. The health service and health provision is now through the Welsh Government and National Assembly for Wales is fully devolved. The powers are fully devolved to Wales, so Wales has complete autonomy over health service provision, and those powers have increased in the last few years. As those powers have increased, the Welsh Government wants to introduce either more legislation or more changes to the way in which health services are provided, and again the BMA would be an instrumental voice in altering or changing the way the government thinks about those things, or changing the way in which some of those provisions are introduced. And increasingly we see coming out of government lots of new laws that they want to introduce. Some of the things that we've managed to influence positively in Wales is as you know, the smoking ban in public places. The BMA in Wales in particular we lobbied very hard, and my public affairs boss here, John Jenkins, is with me today, and was really instrumental in getting that legislation in, and we continue to lobby around the damage that smoking does. We lobbied against sunbeds in local authorities and were successful in getting those removed, given that a lot of young people have had quite severe problems with skin burning and then skin cancers later in life. Changing legislation and lobbying on changes to legislation, or trying to get the government to introduce certain legislation in certain areas, are key sort of things for us. There are new regulations, as I said, that come in. We've been active in trying to support doctors around the new licensing procedure the General Medical Council has introduced, so that now all doctors in the UK, every 5 years are what's called revalidated. They're appraised every year, so they have to bring all their information in terms of how they're keeping up to date and up to standard, and then every 5 years, providing they've complied and participated in that process, get a licence to practice, and if they don't, then their licence to practice is at risk. the BMA's role in that was supporting improved standards for doctors across the UK and the importance of that. Also, were very keen that it was as light touch as possible, because there can be a huge bureaucracy around trying to sort of confirm people's standards, so that people spend more time doing the paperwork to try and confirm that they've got a license to practice than they actually are spending on seeing patients. We are constantly at odds on behalf of our members with health bodies in Wales in various areas because of the current tight financial situation. There is as you will notice if you have any contact with the health service, a real downward pressure on trying to either change or downgrade services, or trying to do it more cheaply or more efficiently, and where we see that that's not in the interests of patients or of our members, then we campaign vigorously to support our members in preventing those deterioration in services. The whole austerity agenda is having a massive impact on the public services, not just in Wales but across the UK. One of the biggest problems that we currently face in Wales, to some extent it is reflected in certain specialities across the UK, is difficulty in attracting doctors to come and work in Wales. There are some GP practices that are currently almost falling over, and one or two that have closed across Wales, simply because there are not enough doctors showing an interest in going into general practice, because of the intensity of the work there, and the lack of the development of primary and community care services to support GPs in that role. We also find difficulty in attracting junior doctors to Wales. As a general perception that Wales perhaps isn't the place that people wanted to come and live and work. And again, we've worked as the BMA in Wales with both government and health services to try and change that perception around and try to get more doctors interested in coming to Wales, because without a clear comprehensive medical workforce, then service provision and the quality of those services are going to be at risk. In delivering all these sorts of things and lobbying on behalf of our members, I've got our main office in Wales is in Cardiff Bay, and I've got about 20 odd staff there that range from people who look after the committees, secretariat staff, legal advisors and employment advisors, a team of media people which are led by my colleague John Jenkins, that do press releases and ensure that we are saying on the right message and saying the right things at the right time to the public. I think generally that the future for the NHS in Wales is pretty positive. I think we're going through a very difficult time at the moment because of the current financial climate. But I think there is, some degree of light at the end of the tunnel, and there is an opportunity for things to increasingly get better, and it's essential that what you're doing here, I think, in terms of keeping yourselves both mentally and physically active by the groups that you are creating, I think is a significant contributor to that. I'm going to finish there. I don't know how long it's taken, but to allow you to perhaps ask any questions about anything that I've said or of general interest, because I can go talking about all the different aspects of health services in Wales, but perhaps it would be useful to know what you think and what you'd like to know from me about it. Thank you.
Thank you, Dr. Lewis, for that very informative talk. Before I invite questions, may I welcome a working colleague of Dr. Lewis, Mr. John Jenkins. Could you just stand, John, please, for them to see who you are, not for them to think that I'm kidding. And he's an invaluable working colleague.
And a Welsh speaker.
Yes, I'm a siarad Cymraeg. Now then, we're open now for questions or comments which you want to direct at Dr. Lewis.
Yes. Now we're a default service, so the health service in Wales and England and Scotland. What happens when English people come to fall ill in Wales and have to be hospitalised and vice versa? Is there
Yeah, that's a very, very good question. The differences between the health service do cause our members some difficulty and patients difficulties, particularly on the borders. So where some of our GP practices or hospital services straddle the border with England, it sometimes creates problems for patients who are not always able to access services in a timely fashion, depending on whether they're registered on because you can have patients who are registered with a practice in England but are resident in Wales and vice versa, and that does cause some degree of problems. In terms of the delivery of the service to people who move around the country, there isn't an issue. You are still part of. There is still the concept of the National Health Service for the entire UK. So people will continue to get services, although the standards sometimes, certainly for waiting lists and waiting times for inpatient surgery, for instance, has some variation between England and Wales and Scotland and Northern Ireland, and that's part of the political footballing, really, is in that people feel that Wales is doing less well than England on some of those issues. But that's a difficult comparison to make, because England as a whole is made up of counties that are bigger and have got bigger populations than Wales, and so when you look at some of the statistics around some of the counties in England and the level of provision, Wales currently sits about in the middle of the table. So if you took all the England and Wales and put Wales as a separate county, all the areas in England, and you rated us certainly against waiting times and service delivery, Wales would sort of sit in the middle of the English counties. So reflecting that everything isn't necessarily brilliant in England in different parts, but often they just compare England with Wales, and the average for England is not a really useful figure to try to sort of compare. Not that I'm trying to defend the role of Welsh Government in Wales or the health services in Wales, but just to reassure you that things are not quite as bad, I think, as is reported in the press and elsewhere most of the time.
Anyone else? Yes, John?
Doctor, you mentioned collective bargaining on behalf of your members, and you also referred in reference to the interests of your clients' patients. Would I be fair to assume on behalf of many people now that the perception of the relationship between client and the GPs is not as it always was? You negotiated very fairly and very effectively on behalf of the members in no longer, as it is seen, being available over the weekends, so that the patients can no longer make access to doctor's surgeries over the weekend. Is it unfair to assume that the availability of patients in an ever-increasing ageing society is not as close to the doctors because of this perception as it was at one time when it was felt that there was access to doctor's surgeries?
That's a really good question, John. When we renegotiated the contract on behalf of GPs some 10, 15 years, I think now, it must be, not far off, I think. Yeah, is it? 2004, yeah, that's right. So there was a real difficulty in general practice, as we're currently facing now, is a workforce crisis. That we couldn't attract young doctors to come into practices that were, as when I started in practice, I was on call one night in 3, and that's not really conducive to a sort of a reasonable work-life balance, and we'd hit a wall really in terms of recruiting people, and it was the desire of GPs that we negotiated the 24-hour responsibility away. That's not to say that there is not access 24 hours to GP services in Wales, because they are outside the sort of 8 to 6:30 time, Monday to Friday, of practices, there are still out-of-hours centres who are manned by the very people who are providing the daytime care. So the service is still available, but it is being delivered in a different way and maybe by different doctors. And I would agree with you. I think the feel from someone who's worked in a service where you've got a 24-hour responsibility seems less comprehensive than it once was, and inevitably people feel that isn't as good a service as it once was, and I think that's entirely right. But that boils down to affordability and also the sort of the workforce numbers, and we're currently facing a similar crisis again, even with people only working, but working. I say only working as if because that's inbuilt in me really, as if 9 to 5, Monday to Friday is the normal way in which everybody else works, but that's not how doctors have traditionally worked really. But working there Monday to Friday, 9 to 5, is becoming increasingly difficult, increasingly complex. And we've been lobbying recently with the Royal College of GPs that 10-minute appointments, which is the current standard across the UK in primary care, is no longer long enough to see some of our patients, because as people are older, they're on multiple medications, they've got complex medical conditions, and you just can't do justice to a patient or to yourself in a 10-minute consultation. But if we were to, let's say, increase that consultation time, that means we could see fewer patients individually in a day, which means that we need more GPs, and currently we're struggling to recruit more GPs even into Wales. So it is a real big problem, and money, while not the be-all and the end-all, the GP salaries have been frozen, I think now, for going into the 5th year of freeze, and that's, again, I don't think any GP would say, I'm really poorly paid. But when other people and other groups are seeing sort of at least some pay rise every year just to sort of combat inflation, there is a limit where people sort of say, well, I don't think this is an attractive profession, and people increasingly in normal life want more out of life. They want lifestyles, and doctors are no different. And so I think in answer to your question, I think things have changed. They are different, and I think a lot of patients would perceive, who experienced the older way of providing and the current way of providing, that it's not as good as it was, and I would agree, but I don't think it'll ever go back the way it was before, despite the current, both, I think, all governments saying that they're going to reintroduce Saturday and Sunday working and surgeries in the evenings and everything. Good luck to them, because I don't think many GPs will be rolling up to do that, I'm afraid.
Anyone else? Margaret?
There's a report in today's press and on the radio, I think you know what I'm going to say, don't you? That by 2020 there will be 33% less family practitioners. What's going to be done to anticipate this, if anything? This they're saying is due to retirement and wastage and going to work abroad, etc.
This is a real dilemma, I think, for UK governments, and we are in constant discussion with the Welsh Government on this to try and improve the way in which general practice and general practitioners are supported. In England, I know the UK government have recently launched an initiative to try to retain people in practice by offering them sort of additional funding. There's schemes to try to ensure that people don't retire earlier, because increasingly, particularly when I mentioned the license to practice and all the hoops that you now have to sort of jump through in order to keep that license, and the standards are good, but for people who are coming to the end of their careers, previously people would have carried on for, let's say, beyond their retirement age for 4 or 5 years, and while not done full-time practice, would have done some part-time work, which bolsters the workforce. But increasingly that's difficult, because people have to jump through all the hoops of revalidation and relicensing just to work 1 or 2 days, or a day or 2 a week. People just don't feel that's very useful. It is an urgent and critical matter that governments grasp the nettle of this, and that is around not just about pay, but it's about the the way that the support for people, the valuing, I think, of people who work in general practice, and acknowledging the fact that it is a really demanding job, increasingly demanding. It's always been demanding, but I think with the complexity of healthcare at the moment, litigation, and people having to watch their backs all the time in terms of the way in which they deliver health care, and an increasingly knowledgeable public. So, you know, you've got to be on your mettle. Long gone are the days where you were the only person that understood how health worked, and you know, you could easily pull the wool over people's eyes if you really wanted to about what was going on. But you know, with the internet and more access to information, we've got really, good that it is, we've got really knowledgeable patients who understand what's going on, and so the level of the conversation is different, but that means longer as well, really, because you can't just, people are not just prepared to sort of say, take these and goodbye and see you, come back if you know better. That isn't the sort of style of consultation anymore, no. It's more collaborative. But yes, I think the GP workforce crisis is a real crisis, and something that governments really have to sort of grapple with if that prediction is to be avoided. Yeah.
Anyone else? Jeff?
I don't think the National Health Service is fit for purpose. Lots of people have had wonderful experiences and they've saved lives and so. Other people have had very bad experiences. The demands that we are putting on the health service now and in the future, as you've shown with your graphs and things, is going to increase, and the supply is not going to keep up with it, even if you throw money at it. We're losing doctors, we're losing GPs, as Margaret just said. Half of the quarter want to retire within the next 5 years. 1 in 5 want to go abroad because they get better money. They must be getting really desperate. They must be fed up because they can see that they're being overwhelmed by the demand that we are putting on them. You can throw money at it, but we haven't got enough doctors, nurses, and health staff. You can get 8 billion for whatever they want to do next year. You can't train a doctor in that time. You've got 5-7 years. We've reduced what for the last 10 years. We haven't enough doctors trained. We haven't enough nurses trained. And you can't produce them out of thin air. So it's not fit for purpose now, and it will be less so in the future because of those reasons.
I think it is getting, and maybe beyond that point, but when you also look at the amount of GDP, the percentage of money that other countries pay on health versus the UK, despite the difficulties that you've just expressed, and the variable service, which I think is something that really needs to be addressed. There should be consistency in the way in which we deliver services, but we're doing it on a funding level that is far inferior to the majority of other countries when you look at the spend on GDP. So we are operating on a shoestring. How much better could it be if we were investing the same amount of GDP as other countries do? We would see a significant step change in the improvement. You know, we're a finite population ultimately, and you know, we can have arguments about immigration and so on, but we are a finite population, and while there are increasing demands and so on, it can be better, but it does require investment, and additional money would make the difference. We've got to do things in different ways as well, and maybe there are expectations, and there's always the debate about the extent to which, you know, people should or have to contribute in some way, either through a mixed sort of economy of private or insurance-based healthcare versus a national provision. The policy of the BMA is to be entirely supportive of a national health system that's funded through the public purse and free at the point of access to everyone. That is our current policy, but you know, clearly that's for you, us, me, the public to decide and to look to our politicians to develop the sort of services that meet our needs, and it's only the public in general, I think, that can decide whether or not they're prepared to pay for healthcare in different
You can
ways.
throw the money at it, but you can't get the doctors straight away unless you get them from abroad, and then you're depleting them from the other country. We've not invested enough in the past to produce the doctors, the nurses and so on. Just like housing. We've underproduced housing. There's a crisis now. It's going to take a long time.
That is absolutely true. Although our numbers of doctors, we are oozing doctors out of the UK, so we would retain more doctors, and we would attract more doctors to the UK if our terms and conditions and the amount of investment that we put into it were improved.
Well, they're going to be homegrown. Others you take them from some other country. Some other country is losing out if you take their doctors away.
Yeah, that's true. But some countries overproduce doctors for their own needs. So there is a, there is a, but we should be as a, in the country that we are, we should be independent in terms of the doctors that we provide. No disagreement with that at all. Yeah, and that is poor workforce planning on behalf of governments. Yeah.
Gwyn?
Presumably, the cost of training a GP far exceeds what the youngsters pay in terms of their university fees. Shouldn't there be some, presumably the rest is made up out of public funds, would it be any sense or perhaps right that they should be asked, those who are qualified, and I mean, perhaps you could tell us how many doctors are qualifying every year, what is the total output of the colleges, but would it be anything be said for them, a requirement that they actually give some service to this country before they depart abroad for attracting
That's a very good point. In terms of total numbers of trained doctors in the UK, I haven't got that figure to hand. But certainly we have explored, and there are schemes across the globe, New Zealand, one in particular, where there is a link to grants and so on. So if you've got a contribution to that, then you have to commit to work in a particular area for X number of years, for instance. And that is one of the ideas that we had taken to Welsh Government, particularly to look at some of the the doctoring of rural areas in Wales, where we're increasingly finding it difficult to recruit doctors to some of the rural areas. Why? I don't know, because the lifestyle there would be absolutely fabulous for many people, but youngsters, younger people these days seem not to want to enter into that lifestyle. And so there are some ideas that fit into that, what you're suggesting, entirely, although the Welsh Government has been, seems currently reluctant to take up that sort of proposition, but it certainly is one way of doing it, yeah, and I think it is an entirely reasonable way to try to attract people to come and provide some healthcare in areas that are otherwise difficult to doctor.
Now I take two more questions. David.
Some countries in Europe are regarded as having much better health services than we do in the UK. France, for instance, has a much higher sense of privatisation. Why is the BMA totally opposed to any privatisation?
The policy position on that is because when you start to look at some other countries, you end up having a two-tier type of system. So you have the haves and the have-nots. So the people who can afford to have a privatised health system pay for it and get a better service, or can access better services than other people who can't. So I think there is some evidence for that disparity, and so on that basis, the BMA's policy has always maintained that a general public purse provision is there. That doesn't mean to say that people can't, as they currently do, pay privately for private health insurance and access that if they want to, but that the norm provision in the UK should be publicly funded in order to maintain that equity of access, I suppose.
But the have-nots still have a better service in France.
The have-nots still have a better service. When there's an international comparison of health systems, and you are right to say that a few places come a little bit better than the UK, but coming back to my earlier point, given the amount of, or the lower level of GDP that we actually spend on health services, we're in the top, I think the top 10 if I remember rightly, of countries in the world that in terms of efficiency, safety, access, comprehensive access, and lack of disparity, that we do exceptionally well when we're compared against other countries. There definitely are a number of countries, and France, I think Belgium also is up there because they have got slightly different. But when you look at how much money, and in fact, when you look at if you look at the insurance, and I've visited a number of the ways in which the health service in France is delivered, and there is some question about where all that money goes and how that money is spent, because people fork out on quite a lot of money to get that service. And when you start doing a comparison against the cost efficiency, so how much you're getting out of it, I don't think, while people are getting a very good service, but they're also paying through the nose for that service too. So I think in terms of how much we spend on health in the UK, we compare very well with other countries. And if we were spending more, I think we would be doing so much better as well if we spent more of GDP on healthcare.
And we've got a national health service which was set up to be free at the point of delivery.
Yes.
So we mustn't lose sight of that.
No.
My daughter in Ireland
David?
spends
No?
40 euros to see the GP with a earache and 45 euros for a prescription.
Yeah. Yeah. And so I think that just, what we don't always do is compare like with like in some of these comparisons, because you don't see the hidden costs because you're not accessing it in the way. And in France in particular, the doctors have really got the stranglehold on contracts and payment and stuff there, and the government have tried to break the doctor monopoly in France, and they haven't achieved that yet. Yeah.
Now, John's got his hand up, but this must be the last. Oh, John?
May I just come back on one point, something we're never supposed to talk about, so immigration.
Yeah.
But is there a population explosion in this country which is putting unreasonable demands on our medical authority, on our medical service?
I think certainly reporting from our members suggests that in some areas, I don't know in terms of total numbers, I'm not really au fait with the total sort of the immigration argument, if you like, around total numbers. But I know that there are migrant populations that settle from Poland, from Ukraine and others. And it's not so much the numbers, but often many of those people are not used to accessing UK health services. They can't speak English, and therefore they take up disproportionate amounts of resources and time, because we have to use translators to be able to speak to them, and so on, and that does put an additional burden on local services, but it's patchy. So you'll get some areas where you've got no significant immigration of populations, and then other areas, for instance Swansea's got quite a large, I think, Polish population in some areas of Swansea, and that works itself through after a while, but it can affect a local health service's ability to deliver, and so it can have a negative impact on it, yes.
Right. Now I'm going to ask Dr. David Parry to move a vote of thanks on our behalf. Incidentally, Dr. Parry is Deputy Vice Chairman of the committee and has been of tremendous help to me during my period of chairmanship. So I'm now going to call on Dr. David Parry to move a vote of thanks on your behalf. Thank you.
Well, it was my suggestion that we invited Dr. Lewis to speak to us. I've known Dr. Lewis for a very long time, and I'm partly responsible for setting on his career in Cairo. We think perhaps of Cairo as being part of the backwoods, but in fact the practice that he went to was one of the finest practices in Wales, if not in Great Britain. One of the doctors there holds a fellowship in both general practice, which is an exceptional honour, and in the Royal College of General Practitioners. One of the partners was the first doctor in Wales to have a distinction in the Royal College of GPs examinations. And so I had no hesitation in inviting Richard, because I knew that he would deliver us a very interesting and informative lecture. And I think from the quality of the questions we've had, he's shown that my expectations were justified. So thank you very much, Richard. Thank you.